Hello, my name is Stela Vujosevic, and I'm head of medical retina unit at the IRCS Multimedica in Milan, Italy, and the associate professor at the University of Milan in Italy. Today, we will talk about the role of inflammation in diabetic macular edema, but from the pathogenesis of diabetic macular edema to imaging, how different biomarkers, especially imaging biomarkers on OCT, can help us to better understand the pathogenesis of DMEO and also how to better treat these patients. DMEO is characterized by retinal thickening involving or approaching the fovea due to abnormal accumulation of fluid in the macula due to diabetes mellitus. The impact of DMEO on patients is really significant. It affects their quality of life. It affects their function and independence, also the ability to drive. It impacts on their requirement to depend on others for daily activities, for example, personal care, eating, and dressing. There is also the loss of work production for those who work still and permanence of employment. And also there is social isolation. So the pathophysiology of diabetic macular edema is complex. And DMEO is caused by an imbalance between the fluid entry, fluid exit, and a retinal hydraulic conductivity, which leads to an accumulation of intraretinal fluid. The major cause is definitely the chronic hyperglycemia, which leads to retinal hypoxia, increase of reactive oxygen species, and also increase of inflammation. And in addition to hyperglycemia, the hypertension and also hyperlipidemia leads to the breakdown of the blood-retinal barrier, to an increase of permeability of retinal capillaries, and it definitely then leads to the formation of macular edema. So an increase in the fluid in the retina parenchyma and a decrease in the efflux of the fluid from the retina. The major risk factors which contribute to DMEO formation are both physiological and pathological. In physiological risk factors, we can definitely include pregnancy, obesity, and puberty. And in the pathological, the chronic hyperglycemia, which is the most important risk factor, as previously said, and also the high blood pressure, the kidney disease, the uncontrolled type 1 diabetes, oxidative stress, and poor levels of lipids, proteins, or vitamin D in the blood. The inflammation, together with hypoxia, they lead to the production of different inflammatory cytokines and chemokines, which include the increase in the VEGF production, Ang2, TNF-alpha, metalloproteinases, interleukin-6, ICAM-1, MCP-1, kallikrein-kinin, and so on. And also the increase of these inflammatory molecules induces a decrease in vascular adhesion molecules between endothelial cells and increases in subclinical inflammation and the production of ROS. This leads to the further endothelial breakdown, the loss of the pericytes, thickening of basement membrane, and leukostasis, which then ultimately lead to further alteration of the blood-retinal barrier and increase vascular permeability. This inflammatory state increases over time, and also VEGF levels increase, leading to chronic refractory diabetic macular edema, which is then obviously harder to treat. These inflammatory cytokines that are increased in both the aqueous and vitreous humor in the eye provide potential targets for treatments of diabetic macular edema. There are numerous biomarkers that we can evaluate on OCT. First of all, if edema is center involving or non-center involving. And that's one of the most important parameters that we use in the evaluation of the treatment. Because if we have center involved diabetic macular edema, generally these patients require the treatment, whereas non-center involved DMEO may be sometimes managed by observation and measures to reduce the risk of progression. For example, with improved blood sugar and blood pressure control, at least at the beginning. Then on OCT, we can evaluate definitely the central retinal thickness. We can evaluate numerous parameters that are signs, for example, of inflammation, such as the presence of hyperreflective retinal foci, the presence of specific pattern of edema, for example, with subfoveal retinal detachments. We can evaluate the cysts in the retina, so the size and the location of the cysts, as well as the reflectivity of the cysts. We can also evaluate the disorganization of the inner retinal layer, so-called the drill, and also the integrity of the outer retinal layers, especially of the external limiting membrane and of the photoreceptors. So definitely these biomarkers can indicate the presence of so-called more inflammatory pattern of edema, which, for example, can be shown also by the identification of subtle signs of progression of the disease that are prior to being clinically evident, for example, from the evaluation on the fundus of the slit lamp. Then we can evaluate different biomarkers, as I mentioned before, in the prognosis of the disease and also for the evaluation of treatment outcome. The presence, for example, of the drill is something that can react better or respond better to the corticosteroid therapy than to the anti-VEGF therapy. And also, for example, the evaluation of the cysts in the retina. If we have very large cysts in the retina, maybe the sign of the chronicity and that these patients may better respond to the steroid treatment than to the anti-VEGF. Also, the presence of different, more than one parameters in the retina, such as, for example, the subfoveal retinal fluid, the hyperreflectivity of the cystoid walls, and also the vitreomacular interface alterations, were also the parameters that could certainly indicate the failure of anti-VEGF treatment. So, identifying early different OCT biomarkers could indicate the patients that may benefit from the treatment with steroids from the beginning, or, for example, for the early switch treatment. So the patients with DME who start on anti-VEGF treatment, I usually do the loading dose of the specific anti-VEGF treatment, and then after the loading dose, I evaluate the patients. With the OCT, I look at all different signs, I would say, of the response of the treatment on OCT. So the change in central macular thickness, in the volume also, but not just the change in the fluid, the change in different parameters, such as, for example, if there is a decrease in hyperreflective foci, if there is a decrease in hard exudates, the decrease in also the extension of the drill if present at baseline, and also what is the integrity of the outer retinal layers. Then when I see how is the change of all of these parameters and the relation to visual function, and if I don't see, let's say, a good response, I try to switch the treatment. So I think that today what we have learned is that there is no need to stay, let's say, on the same drug for very long time if we don't see a good functional and morphologic response. Then it is better to change early the drug to give the possibility to the patient to have a better response to some other treatments. So DMEO is definitely an inflammatory condition of the retina where the increase of different cytokines and chemokines has been proved in numerous studies besides the VEGF. Not all patients respond well to anti-VEGF treatment, even if it is considered the first-line treatment. And there is a significant number of patients that need other therapeutic strategies, such as, for example, the corticosteroid treatment. Identifying early these patients may lead to better also functional outcomes in these patients.
My name is Francesco Bandello. I am the chair at the University Vita Salute San Raffaele. I'm chairing the ophthalmology department. And today I'd like to speak about the role of steroids in diabetic macular edema. And maybe at this time we need to have a look on this topic, which is a very important topic for patients affected by diabetic macular edema. How do corticosteroids affect diabetic macular edema? This is a very important question. And we must remember that steroids are characterized by the first important anti-inflammatory effect, which is the most important effect of any steroids. And then we have also an effect on vascular endothelial growth factor expression, which is reduced by steroids. We have also a stabilization of the blood-retinal barrier, and we have a reduction in vascular permeability. So all these effects are extremely important for treating patients with diabetic macular edema. Do we have already data supporting the use of steroids in diabetic macular edema? I think absolutely yes. We started to have data about the importance of triamcinolone many years ago. I was among the first to use triamcinolone in patients with diabetic macular edema intravitreally. And the results from the efficacy point of view were really very important. And we were all impressed by the effect of triamcinolone intravitreal in patients with diabetic macular edema. But unfortunately, after some time, we started to see that there were a lot of patients with an important increase in glaucoma and also for development of cataract. And for that reason, we stopped the use of triamcinolone. But after some time, dexamethasone arrived. And this formulation of dexamethasone, which is able to stay inside the eye for several months, was used in some important clinical trial. And we were able to show that using this formulation of dexamethasone, it was possible to have an important improvement in visual acuity, a significant reduction in diabetic macular edema. And these results, and this was the main difference compared with triamcinolone, were obtained without significant side effect. Cataract and intraocular pressure increase were present, but in a very small percentage of cases. And intraocular pressure increase was always possible to be controlled using eye drops, anti-hypertension eye drops. The third steroid which was used was able to stay inside the eye for a very long time, for 3 years. fluocinolone acetonide in the formulation that we use is maybe the most rational approach for diabetic macular edema, because we have this microdose of steroid which is released inside the eye for 3 years. And this is, it seems to me, a chronic therapeutic approach for a chronic complication, which is what we need. And unfortunately, anti-VEGF at the moment is not able to guarantee the same kind of approach, because we have an acute therapeutic approach for a chronic disease. Thanks to this kind of long duration, it was possible to reduce a lot the burden for patients with diabetic macular edema. But also in this case, the side effects produced by fluocinolone were important. Increase in intraocular pressure and cataract became really important side effects for this kind of steroid. We have today many anti-VEGF, we have steroids. So the point is, how do we start treating our patients? Is there any possibility to use steroids as the first line treatment? Is there some subgroup of patients with that can be treated with steroids as first line treatment? And this question is made very important because, as you probably know, we have 30 to 40% of our patients with diabetic macular edema who do not show any response to anti-VEGF approach. So there is something wrong in the system. I mean, we cannot solve the problem of diabetic macular edema using only anti-VEGF. So these two studies, the Paladin and New Day study, were able to show that the use of steroids were able to produce really very good therapeutic effect without significant complications. And also, if you consider the long-term results of these patients, you do not see significant complications. We have other studies such as the Bevordex, which was a study where dexamethasone implant was used each 4 months versus bevacizumab every 4 weeks in center involving diabetic macular edema patients. And the study was able to show that the results were absolutely comparable. We had an important effect on visual acuity, an important effect on central macular thickness, and the reduction in the central macular thickness was better with the dexamethasone compared with bevacizumab. And after 5 years, as you see, the results from a clinical point of view were similar, from a functional point of view as well as from the OCT point of view. Who are the patients that we can consider first for treatment with steroids instead of anti-VEGF? We can say that these patients are pseudophakic because, as you know, pseudophakic patients do not have any risk for cataract, are patients where the inflammatory component of edema many times is important, so the use of steroids can be very useful to control these aspects of diabetic macular edema. And then we have patients that cannot be assigned to anti-VEGF treatment. I'm speaking about patients with recent arterial thromboembolism events, or pregnant women, or patients that are not able to follow, to be adherent to the anti-VEGF treatment. And also some other specific groups, such as patients with the presence of hard oxidates in the center of the fovea, or where doing our OCT evaluation, we see that there are some inflammatory component in the OCT exam. And for sure, finally, patients already submitted to vitrectomy where the formulation of dexamethasone can stay inside the eye for a long time. Otherwise, the anti-VEGF stay inside the eye only for few days or weeks. So if you want to try to summarize this very, very short talk, I like to say that the pathogenesis of diabetic retinopathy is very complex. And although the role of vascular endothelial growth factor must be considered very important, it is not the only one that is responsible for the retinal complication. And we know well that in approximately 40% of cases, intravitreal injections of anti-VEGF do not produce an improvement of diabetic macular edema, confirming that vascular endothelial growth factor is not the only determinant for this complication of diabetes mellitus. Steroids, thanks to their effect on many pathogenic moments, represent an effective and often definitive alternative solution. In some specific clinical situations, intravitreal steroids may represent the first choice therapeutic solution. Thank you so much for your attention.
Good morning, ladies and gentlemen. It's my real pleasure to be with you today. I'm Professor Laurent Kodjikian. I'm working in France at Croix-Rousse University Hospital, and I'm also the past president of the French Society of Ophthalmology. Today, I'm going to speak about personalizing DME management and how to select the different therapies we can use to treat those patients. So the different questions we are going to answer is why, when, and how. We have different therapeutic strategies for the management of diabetic macular edema. We have the laser. It's more the focal laser, and please forget the grid laser. And we have anti-VEGF agents or intravitreal steroids. For anti-VEGF agents, they are more generally used in first line. And you find the first generation, ranibizumab or aflibercept 2 mg, and their biosimilars, or the second generation, like brolucizumab, faricimab, or aflibercept high dose. On the other hand, you have the intravitreal steroids like dex implant or fluocinolone acetonide implant. They are generally used in second or third line, but you can use dex implant in first line. Of course, we can use both and all of them in combination in combo therapy. It's really important to understand that in DME patients, VEGF is increased, but also different cytokines like interleukin 6, 8, or MCP1. And what is really, really important to understand is that VEGF is not increased in the vitreous of all of eye patients with DME. And we estimate that about 1/4 to 1/3 of these patients have a normal VEGF level, even if they have diabetic macular edema. And if you treat with anti-VEGF a patient with a normal VEGF level, the patient will not answer. And we have the proof. And in this study, you can see that eyes with normal and low acute VEGF level will have a delayed or no response to anti-VEGF. On the other hand, we know that we have interleukin 6 and other cytokines that are elevated, increased in patients with DME. So it is really important to treat these inflammatory cytokines. And for that, we are going to use steroids. But it's also important that we have a real burden of treatment. We have a higher percentage of non-adherent patients in diabetic macular edema. And you can see the link between non-adherence and visual acuity impairment. So we need also to find the treatment easier for the patients. And here you can see the different appointments that are mandatory for a DME patient. And again, we have another burden with the anxiety of our patients. Each injection appointment in ophthalmology took an average of 4.5 hours. 53% needed to take 1 day off per appointment. And of course, there are also assistants. So for the grandmother, the son or the daughter. And so there is a real burden for the society. It's important to understand that we have functional and anatomical non-responders to anti-VEGF and some predictive biomarkers that are, for example, inflammatory biomarkers like serous retinal detachment or hyperrefractive foci also are a good reason to switch. We'll not have enough time today to speak about the predictive biomarkers, but you have to understand, to remind that they are existing. So about the functional non-responders, you have to remember that the rate of non-responders to anti-VEGF, for example, in RESTOR studies, the pivotal study for ranibizumab in Europe, the rate was 1/3, 35% during the first year. If you look the rate for the patients that continue to receive anti-VEGF during the third year, 34%. So you remember, I said to you, 1/3 have a VEGF level normal, 1/3 are functional non-responders, and you can see here that obstinacy is not a guarantee of success. On the contrary, delayed treatment is a loss of opportunity because duration of edema matters. If we treat effectively but too late, after 2 years, the sham group, it's too late, and the patient will not obtain the same level of the gain that the patient initially treated with anti-VEGF. And the longer the duration of DME, the more the visual acuity decreased. So again, duration of edema matters. Can we predict a functional response to anti-VEGF therapy? Yes, we can predict with anti-VEGF after the first 3 to 6 injections. And so it's really important to understand, and it's really important to switch earlier than before. So don't wait anymore 9, 12, 15 injections before switching. See, if you treat in first line with anti-VEGF, if the patient is functional non-responders, switch after 3 to 6 injections. The second part is the anatomical non-responder to anti-VEGF. In all the studies with the first generation anti-VEGF, but also the new anti-VEGF generation, you can see you have aflibercept, brolucizumab, faricimab. We have a great decrease in sickness, minus 120, almost minus 200, and you can see, wow, they are so effective anatomically. But finally, it's not the reality, because if you look at the presence of fluid, intraretinal fluid or subretinal fluid, here you can see that the level is very important. And I showed to you a very good example. This patient decreased by 120 microns, but you can see that there is visual acuity remains stable and there is still some intraretinal fluid. There is really limited evidence supporting the benefit of switching between anti-VEGF agents. So really remember that if you don't have a good efficacy with an anti-VEGF, it's better to switch to another drug, another class, another family of drugs like steroids. The switch to steroids has shown benefits when used earlier in the treatment pathway. I published the REDEX study many years ago now, 8 years ago, and the pre-diabetic study 7 years ago also. Look at the duration of DME. 2 years for REDEX, 2 months for pre-diabetes. Look the proportion of naive patients, 26% for REDEX, 73% for pre-diabetes. And you can see that the gain of plus 10 letters was obtained after 3 years for REDEX, but as soon as 2 months for a pre-diabetic study. And we have the same impact with a phakic implant. And you have very recently the New Day study, which is a randomized multi-center study with phac versus aflibercept in treatment-naive patients, 90% of this cohort. And you can see that phac implant demonstrated comparable mean visual acuity gains, especially in pseudophakic groups, with less anatomical fluctuations and less injections, 3.4 versus 7.5 for 18 months. Of course, we have some drawbacks with these steroids. We could have cataract issue. If we treat patients with our phakic, we will have a cataract after 3 or 4 DEX implants or after only 1 phakic implant, as the duration is 3 years. And of course, we have some intraocular hypertension with these steroids, but nevertheless, it's limited. And for example, for DEX implant, it's 30%, but it's controlled by a topical treatment in 97% of the cases. And you see with phakic implant, it's globally the same key messages. So it's not so difficult to control this hypertension, and the need of surgery for IOP control is really, really limited. We have two intravitreal steroids. You can use DEX implant 6 mm in length, or FAC implant, flow and sling implant, 3.5 mm in length. And you can see that the indication is completely different. DEX is indicated, could be indicated in first line for patients that are unsuitable for non-steroid therapy, or pseudophakic, or who are considered insufficiently responsive to anti-VEGF, second line. And for FAC in Europe, different in US, in Europe, it's considered for patients with chronic DME, considered insufficiently responsive to available therapies. So second line or third line. And it's very important that these two to understand that these two implants are completely different. We have two different pharmacokinetics, and so we have two different goals. They are not really concurrent; they are complementary. We have a burst in steroids, but after 4 months, the level will really decrease. For FAC implants, there is no burst, but there is a prolonged level of steroid during 3 years. We have to change the paradigm of the treatment with steroids in DME. DME treatment includes attack treatment, which is aimed to dry rapidly the edema. It's more for DEX, and background treatment, which is aimed at decreasing the frequency and intensity of relapses, and the number of additional treatments, and to improve quality of life. Now, for FAC implant algorithm, we have different situations. Either anti-VEGF are the patient that are anti-VEGF non-responders, or there is a real treatment burden, and we use DEX implant, or DEX implant was used in first line. And now we have two different situations. We have to check, before using FAC implant, we have to check the absence of hypertension with at least 1 or 2 DEX implant. And we have two situations, DEX implant responders or DEX implant non-responders. For the DEX implant responders, either the treatment frequency is acceptable for the patient and for the physician, either it's not acceptable for the physician and or for the patient. And the objective to use FAC implant is a little different in the order. If the treatment frequency is acceptable, we can use FAC implant to prevent DME recurrence, to reduce anatomical fluctuations, and of course, to decrease treatment burden nevertheless. If the treatment frequency is not acceptable, the first goal is to decrease treatment burden, but also to prevent DME recurrence and to reduce anatomical fluctuations. And for DEX implant non-responders, the objectives are to sustain, to switch to a sustained steroid release, and to hope to have a possible anatomical and or functional improvement. Of course, when you use FAC implant, either you inject a FAC implant alone, and if it's not enough at 1 month, you complete with the DEX implant. Either you can inject a DEX implant followed 1 to 4 weeks later by a FAC implant. To finish, I would say that inflammation is a central and early process in diabetic macular edema. Approximately 40 to 60% of patients who have a suboptimal functional and or anatomical response to anti-VEGF. DEX implant is effective with good durability and no compromise on side effects, and long-acting steroids such as the FAC implant reduce the frequency of treatment and prevent retinal thickness fluctuations. Remember, don't wait for huge anatomical recurrence, treat early or use FAC implant to have no anatomical fluctuations. Thank you for your attention.